Today, we are really getting into something important, something quite personal, actually. It's about medication-assisted treatment for opioid use disorder.
That's right, MAT. Specifically, we're looking at the reality of long-term use, with medications like Suboxone, which contains buprenorphine.
And this big debate, this really contentious issue, is it meant to be a lifelong thing, or is tapering off the goal? Maintenance versus, well, abstinence.
So our mission here is to try and unpack the trade-offs. We'll look at system-level data, big picture stuff, but also the human side of it.
We're going to follow one person's journey, Stacy. She was stable on Suboxone for 9 years. Functional recovery.
9 years is a long time. And now she's making this decision, a really high-stakes one, to aim for abstinence using Sublocade, which is another form of buprenorphine.
So we want to place her story alongside the clinical facts, the policy changes, and that persistent stigma.
Exactly. Let's start there with Stacy, because her experience really frames the whole conflict.
It does. Her addiction, like so many, it started with doctor-prescribed Vicodin, but it escalated fast. At one point, she was taking 20 pills a day. She was, holding down a job, caring for her kid, but 20 pills.
The cost alone. She mentioned $3 a pill. That's $60 a day. Just unsustainable.
Completely. And then Suboxone came into the picture, and it genuinely saved her life. Her sister tragically died from an overdose at 25, so the stakes were incredibly high.
Absolutely life-saving. But here's the conflict. Even after 9 years of stability, Stacy described Suboxone as, well, another addiction. She called it a crutch.
That feeling is so common, isn't it?
Yeah.
The medication helps you rebuild your life. She got an apartment, a car, trained as a recovery coach.
All signs of successful recovery.
Right, but there's this external and sometimes internal pressure. This idea that real recovery means being free of everything, even the medication keeping you stable.
It's a profound tension. Okay, let's maybe step back and look at how Suboxone prescribing has changed, because Stacy's early experience was very different from today.
Yet she said 10 years ago, getting it was highly structured.
How so?
Well, only certain doctors who were vetted, could prescribe it.
Yeah.
And there were mandatory requirements. You had to admit the problem to family, go to rehab first.
Right. There were strings attached, meetings, counseling, real accountability built in.
Exactly. That was the foundation then. Balancing the access with, actual support.
But that changed.
Dramatically. Stacey said that structure started to erode, especially just before and then during the COVID pandemic.
Ah, okay.
Suddenly, prescribing was everywhere. Pretty much any doctor's office, she said, and the accountability part just started to go away.
That's concerning because without that support structure, risks emerge.
Big risks. Stacy herself experienced this. She found she was being prescribed way more than she needed. 3 8-milligram strips a day.
But she only needed
one. Just one strip kept her stable. So she had this huge surplus of a controlled substance every single month.
And what happened with the extra?
She admitted she sold it, made an extra $500-600 a month.
Wow. So the medication meant to treat the addiction inadvertently provided funds.
To basically support the habit, yeah.
Yeah.
Pay for cigarettes, food, other things. All funded by the treatment itself. It's a paradox.
It really highlights that challenge. Increase access, but how do you maintain oversight and prevent diversion?
And it wasn't just about funding her own habits. Stacy mentioned something else alarming she saw, I think, when she was in jail.
Oh.
That Suboxone was being offered even to people who didn't use opioids. Like methamphetamine users with no known opiate history were being offered it.
That's risky because someone who isn't opioid tolerant can get high from buprenorphine. It creates potential for abuse where there wasn't opioid use before.
And the danger gets worse when it's mixed with other things, right?
Yeah.
She mentioned getting prescriptions for benzodiazepines like Klonopin and gabapentin alongside the Suboxone.
Oh, that's a classic and incredibly dangerous combination. She said she was getting 90 pills of all three, monthly.
Yeah, just 5 years ago. Can you explain why that specific mix is so lethal? For listeners who might not know the pharmacology.
It's all about additive, or rather synergistic respiratory depression. Benzos are sedatives. Gabapentin, often prescribed off-label, also has sedative effects. Buprenorphine, while having a ceiling effect on respiratory depression compared to full agonists like heroin, still slows breathing.
So you put them all together.
And the combined effect just shuts down the drive to breathe. It's not 1 + 1 + 1 = 3. It's much more dangerous. As oversight loosened and maybe prescribing happened in silos, one doc for Suboxone, another for anxiety meds, this co-prescribing became terrifyingly common.
Which really sets the stage for this major policy shift aimed at fixing the access problem, removing the X waiver. That happened late 2022, early 2023.
The AMED Act, yeah. The Mainstreaming Addiction Treatment Act.
For people who aren't familiar, what exactly was the X waiver and why was getting rid of it such a landmark change?
Well, the X waiver was this extra certification from the DEA. Doctors, NPs, PAs needed special training and this waiver just to prescribe buprenorphine. And crucially, it capped the number of patients they could treat. So it created huge bottlenecks, especially in rural areas where maybe there was only one waivered doc for miles.
Right, a massive barrier.
Removing it meant basically any clinician with a standard DEA license to prescribe controlled substances could now prescribe buprenorphine. No patient caps, no extra training mandated at the federal level.
So the doors flew open. What did the data show? Looking at, say, 2018 through early 2024, what happened?
Well, it definitely achieved the goal of expanding access, broadly speaking. The total number of patients getting buprenorphine prescriptions jumped nationally by 53%.
53%, that's huge. From around 644,000 patients to nearly 1,984,000.
A massive increase. But here's the really interesting part, the nuance. That growth was almost entirely driven by continuing users, people staying on it longer.
Wait, hang on. If it got so much easier to prescribe, wouldn't you expect a flood of new patients starting treatment? Why was it mostly existing users?
That's the million-dollar question. It suggests a couple of things. First, the number of new people starting MAG each month actually dropped by 33%.
Dropped, even with easier access.
Dropped, which might mean we're still facing barriers in reaching people early in their addiction, or maybe other factors are at play. But second, it strongly confirms that buprenorphine is functioning primarily as a long-term maintenance medication.
People are staying on it for extended periods.
Yes. The data showed more patients being dispensed the medication for longer durations. Specifically, the number of people getting more than a 120-day supply increased steadily month after month.
So long-term use is really defining the current landscape. What about the prescribers themselves? Who stepped up once the X waiver was gone?
The provider profile changed dramatically. The total number of unique prescribers shot up 36% after the waiver removal. And guess who's leading the chart?
Let me guess. Primary care. Nurse practitioners.
Nurse practitioners, exactly. They are now the top specialty prescribing buprenorphine. Their prescribing numbers increased by a staggering 1,266% since 2018.
Wow. 1,266%.
Physician assistants also saw a huge jump, up 826%. So yes, it's heavily shifted towards primary care providers, NPs, PAs, the clinicians people see regularly.
Which was the intention, right?
Yeah.
To mainstream it. But you mentioned unintended consequences earlier, linking back to that lack of structure Stacey talked about.
Absolutely, especially in rural or underserved areas.
Yeah.
Even though legally more providers can prescribe, many primary care docs still report major hurdles.
Like what?
The biggest one is the lack of those wraparound services. Mental health support, counseling, psychosocial support, the things Stacey had mandated early on, they just don't exist in many areas.
So a doctor can prescribe the medication, but they can't ensure the patient gets the behavioral therapy that's often crucial.
Precisely. Even if state law technically requires counseling, the infrastructure isn't there. So doctors are hesitant. They worry about getting an influx of patients. They feel ill-equipped to manage comprehensively.
And maybe some lingering reluctance.
Yeah, you hear about opioid fatigue in communities hit hard by the epidemic. Some providers might just be wary of prescribing any opioid, even a life-saving one like buprenorphine.
This really brings us full circle back to Stacey. She's doing well, technically. Apartment, job, training as a recovery coach.
By all objective measures, thriving in recovery.
But she's still battling that stigma, that feeling, maybe from others, maybe internal, that if you're on Suboxones, you're not sober.
And that stigma isn't just hurtful, it's actively dangerous. It pushes people towards stopping their medication too soon, which goes against basically all the clinical evidence.
We have to be clear about this. The goal of MAT has always been about rehabilitation, achieving remission, getting stable.
Not necessarily immediate abstinence from the medication itself. That might be a long-term goal for some, like Stacey now, but it's not the primary clinical goal for everyone, certainly not initially.
And when people are pushed towards abstinence or choose it without full support, the data is pretty scary.
It's incredibly stark. Buprenorphine is protective. There was one big study looking at a 90-day Suboxone taper just 3 months. Over 90% of the clients relapsed back to illicit opioid use afterwards.
Over 90%.
Another review found most people who try to withdraw from buprenorphine don't succeed long-term. Relapse rates were over 50% just 1 month after stopping.
So The odds are heavily stacked against successful short-term tapering for most people.
Very much so. And then there's the even more alarming finding about what happens when people are in treatments that don't include medication.
Right, you mentioned a Yale study.
Yes. It found that non-medication-based treatments, think traditional abstinence-only programs, actually increase the risk of dying from an overdose by over 77% compared to getting no treatment at all.
Increase the risk. More than doing nothing.
Oh. Because if someone achieves abstinence through such a program, they lose their tolerance to opioids. If they then relapse, which is common, that first use back can be fatal at a dose that previously wouldn't have been. MAT, like Suboxone, maintains some tolerance and blocks the effects of other opioids, providing a safety net.
That's a chilling statistic. It really forces you to think differently about what successful treatment means. Maybe we should see it more like managing a chronic illness, where stability on medication is success.
That's the consensus in the medical community. Staying in MAT significantly reduces the risk of death from all causes, especially overdoses. For many people, maybe most, long-term treatment is needed. For some, it might need to be lifelong.
Okay, but despite all that evidence, Stacy, after 9 successful years, is choosing to pursue abstinence. And it sounds like it's coming from her, not external pressure. She wants to feel my emotions, know who I am without all this. 10 years on some kind of drug, first Vicodin, then Suboxone.
It's about her personal autonomy, her definition of recovery at this stage, and that choice, even with the known risks, has to be respected and supported medically.
How is she approaching it? What's the plan?
She's transitioning to Sublocade. This is actually a really smart approach for someone wanting to taper after long-term stability.
Sublocade. That's the injectable form, right? Once a month.
Exactly. It's an extended-release injection of buprenorphine given by a clinician. A key benefit, mentioned in the source materials, is that it drastically reduces the diversion risk compared to daily strips or pills. You can't sell your monthly shot.
And how does it help with tapering?
It provides a very steady level of medication, avoiding the daily ups and downs. And because it wears off very slowly over weeks, stopping the shots essentially creates a very gradual, natural taper as the drug level diminishes in the body. It's smoother than trying to cut down tiny pieces of film.
That makes sense. But tapering off buprenorphine, even slowly, isn't easy, is it?
Not at all. It needs to be done very carefully under medical supervision. Withdrawal can start 12 to 48 hours after the dose drops significantly, and the physical symptoms, aches, nausea, insomnia, can last for weeks, maybe up to 20 days or more, with psychological symptoms lingering even longer.
It's a serious undertaking.
Absolutely. And for someone like Stacy, who's been stable for nearly a decade, the idea of not having to take a medication every single day, of not being, as she put it, tethered, like dragging this like ball around with you, that desire for freedom is powerful.
So the goal is honoring her ability to make that decision, while giving her the best tools like Sublocade and support to do it as safely as possible.
That's the ideal, yes. Balancing the population-level data, which screams stay on MAT, with the individual's right to choose their path, supported by good clinical care.
Okay, so wrapping this up.
Right.
The big tension we've seen is this push-pull between access and structure. MAT, buprenorphine, it saves lives. It allows for functional recovery, no question.
Undeniable.
But when we expanded access rapidly, removing things like the X waiver, we didn't always ensure the support structures kept pace. That lack of integrated psychosocial support creates problems.
Yeah, it opens the door to issues like the diversion Stacy experienced, or maybe a drift away from a focus on holistic recovery because the counseling just isn't there or isn't required.
Meanwhile, the clinical data is overwhelmingly clear. Long-term AT is highly effective, often essential for survival.
Definitely. Retention is key to reducing mortality. But that medical reality bumps up against personal goals, that deep-seated societal stigma about being on medication, and now this landscape of easier prescribing but potentially less support.
So for you listening, if you're on MAT or supporting someone who is, the message seemed to be, there's no single right answer about duration.
It really comes down to an individual conversation. Talk honestly with your doctor. Weigh the risks and benefits for your situation. Lifelong maintenance is valid. A carefully planned, medically supervised taper is also valid if that's the goal. It needs to be personalized.
Before we finish, let's just touch on that one last piece of data, because it felt really important.
The age disparity.
Yeah. While overall patient numbers went up 53%, the number of young people, 18 to 24, getting buprenorphine actually dropped 41% between 2018 and 2024. And 25 to 34-year-olds dropped 17%.
It's a stark contrast. Access is supposedly easier than ever, yet these younger, high-risk groups seem to be connecting less with this life-saving treatment, even as older, perhaps more chronic users are staying on it longer.
Why? If we've made it easier for doctors to prescribe, what's stopping younger people from getting this help? That feels like a critical question we need to figure out.
It really does. Is it stigma hitting them harder? Problems navigating the healthcare system? Different patterns of drug use? It points to a major gap in our approach, even as we celebrate expanded access overall, something for us all to think about.